Okay, good afternoon, everyone. Welcome to Medical Grand Rounds. Before we begin, I would like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Before we get started, I'd like to ask Dr. Alain Bitton, who is our Chief of the Division of Gastroenterology, to introduce our speaker today, who is from the Division of Gastroenterology. Alain, thanks for being here, and I'll let you introduce our speaker.
Okay, well, thank you very much, Nadia. So it's a great pleasure to introduce Dr. Xun Zhao, Assistant Professor who just joined our division this past summer. So Dr. Zhao received his MD from McGill University, and then he trained with us in GI during residency. And this was followed in the last previous 2 years of a Transplant Hepatology Fellowship at Toronto General Hospital, and then a 1-year Hepatocellular Carcinoma fellowship at Princess Margaret Cancer Center. And currently he's actually completing a PhD in clinical epidemiology. So it's a great pleasure that we have Xun join our ranks, and today he's going to talk to us about immunotherapy and hepatocellular or carcinoma. So Xun, welcome, and we look forward to your talk.
Thank you, Professor Bitton, for the introduction. Thank you for the opportunity of presenting at the Grand Rounds. So the topic today will be immunotherapy in the context of HCC. So the presentation outline, we're going to have a high-level overview of the epidemiology of HCC, and then the general diagnostic approach, along with the overview of the current treatment options that are available with HCC for early stage, intermediate stage, and advanced stage. And then we're going to go into how the addition of immunotherapy has really changed the landscape of HCC in the last 5 years, and how the addition of immunotherapy at all stages of HCC might be a possibility in the very near future. So primary liver cancers are the 6th most common cancer and 3rd leading cause of cancer-related death in the world. HCC, hepatocellular carcinoma, is the dominant entity here, 75 to 85% of primary liver cancers. There are risk factors associated, the strongest one being cirrhosis from any etiology. So 80% of people with HCC have underlying cirrhosis. And in patients with cirrhosis, we quote usually a 2% annual risk of developing HCC, which justifies screening protocols. Otherwise, chronic viral hepatitis, hepatitis B, hepatitis C, and mostly in areas without robust viral hepatitis elimination programs or prevention programs, is still a driving etiology for developing of HCC. And there's also emerging risk factors such as metabolic syndrome-associated liver disease, which is a new term for fatty liver, MASLD, or alcohol-related liver disease, or a combination of both. This is from the AASLD latest guidelines. As you can see, the epidemiology of HCC is very asymmetrical. In the developing world, where some of the hepatitis eradication programs are less robust, we still have hepatitis as one of the leading causes, whereas in North America, in the developed world, we have fatty liver, MASLD, and alcohol-related. There are other cofactors that are less directly related to the cause of HCC, but more synergistic, such as tobacco smoking. So we see a 20% to 86% increase of HCC with tobacco smoking in patients who are at risk, and the cessation can normalize risk, which is often the case for many morbidities related to smoking. Metabolic syndrome, namely obesity and type 2 diabetes, are also associated with it, and dietary exposure to aflatoxin B1 and aristolactic acid, which are found in cereals in certain areas of the world, can be an agent that causes HCC. So in terms of primary prevention, nothing is better than treating the underlying cause, and hepatitis B, hepatitis C are treatable entities. There are other chemopreventive measures that are based on observational studies: coffee consumption, aspirin, statin, mostly the lipophilic statins, and metformin. So much so that coffee is actually part of the recommendations for HCC prevention, but there's insufficient data to recommend any specific dose. So I guess the current message we would have for patients if they drink copious amount of coffee would be no reason to stop it, but nothing specific for recommendation. As opposed to the medications, aspirin, statin, metformin, we still don't have enough data to formally recommend it solely on the premise of primary prevention. In terms of surveillance, there's been improved survival shown in Child-Pugh A or B cirrhosis, but not in Child-Pugh C cirrhosis outside of transplant candidacy, because the high competing risk of liver-related mortality means that these patients will more likely pass away from a liver-related complication from cirrhosis than developing a cancer. And we also screen non-cirrhotic HBV with high risk factor, which we'll go into here. So this is also from the AASLD. We will screen with ultrasound every 6 months any patients with cirrhosis, Child-Pugh A or Child-Pugh B, and chronic hepatitis B from endemic countries at age 40 for men and 50 for women. And a person from Africa should be screened at an earlier age, some say as soon as diagnosis, or any family history of HCC, which is an independent risk factor for developing HCC. There are many scores that try to prognosticate the risk of developing hepatocellular carcinoma, and the only one that's been really robustly assessed in a multi-ethnic large cohort of patients across several countries is the PAGE-B score, which is specifically applied for hepatitis B. And you can see this publication from the Journal of Hepatology shows that a PAGE-B score, which is based on risk, sex, platelet, albumin, and age, over 10, you have a increased cumulative probability of developing a hepatocellular carcinoma. Of note, hepatitis C and stage 3 fibrosis and non-cirrhotic fatty liver are known to be associated with an increased risk of hepatocellular carcinoma. However, it's very heterogeneous. We cannot really identify for the moment which patients among these groups will develop HCC, and the overall risk is less than 0.2%. Therefore, not enough recommendations, not enough to warrant a recommendation for formal screening. But my general approach with these patients is that if they have other cofactors, smoking, obesity, I generally screen them as if they will be part of the at-risk population for surveillance. There's emerging data on CT and MRI-based surveillance, but the recommendation is still ultrasound with alpha-fetoprotein approximately 6 months, which yields a sensitivity of 61%, 92% specificity. This is the algorithm, essentially every 6 months based on the visualization score of your ultrasound. Anything that essentially gives you doubt that the quality of the image is not as rigorous warrants a repeat, and anything that is suspicious warrants a diagnostic test, which is a multiphasic CT. So the diagnosis of hepatocellular carcinoma is quite interesting. Unlike most cancers, because of specific non-invasive imaging characteristics, we can diagnose it without histological confirmation in most cases. The arterial phase hyperenhancement and washout on portal venous phase or delay phase multiphasic CT have a very high positive predictive value in lesions greater than 1 centimeters. So the integration of all these imaging features, size, and growth gives us a LIRADS diagnostic algorithm. It goes from 1 to 5. And the probability of HCC based on LIRADS is as LR1 being definitely benign and LR5 being definite HCC. We're looking at an accuracy of 95% here. Anything in between may warrant either follow-up or, if necessary, biopsy for pathologic diagnosis. It's important to mention that LIRADS score has only been validated in people who are at risk of developing HCC. That's part of the screening recommendation. So cirrhosis and hepatitis B who are at risk. If a patient without cirrhosis has a suspected lesion, the LIRADS score does not apply here, and you sort of need the diagnostic confirmation with pathology. So staging of HCC is also a bit different. Every patient needs a high-quality multiphasic CT or MRI to appreciate the tumor extent, and lesions of at least 2 centimeters suggests that we also get a CT chest for initial tumor staging for extrahepatic spread. And also a recommendation that this be discussed in the tumor board with an expert radiologist. The staging is based on 3 general concepts: tumor burden, the degree of hepatic dysfunction, and the patient performance status. There's multiple staging systems that exist, none of which have been universally accepted, but the Barcelona Liver Clinic cancer staging is the most commonly applied algorithm, and it's recommended both by the American Association for the Study of Liver and the European Association for the Study of Liver. It incorporates liver dysfunction, of course, the tumor characteristics, and Eastern Cooperative Oncology Performance Status, the ECOG. So this is essentially what it looks like. I know it's a quite crowded slide. Very early stage, we're looking at a single lesion less than 2 centimeters with preserved liver function and excellent performance status. Early stage is what is within Milan criteria, single or less than 3 nodule, less than 3 centimeters. And when you're looking at intermediate stage, we're looking at multinodular disease with maybe satellite lesions, but still some preserved liver function. And the advanced stage is looking at patients with portal invasion, extrahepatic spread, or some sort of liver function or performance status that is less ideal. We'll go through them individually and see what's going on. So the multidisciplinary care for HCC is very important because the treatment options include surgical, local, regional, and systemic therapies. And some patients may benefit from a combination of interventions. Therefore, we require interdisciplinary input to decide what's the best approach. And it's been shown that presentation of HCCs in interdisciplinary boards actually changes the imaging and histological interpretation in 10 to maybe 20% of cases. So early stage HCC, which is the single lesion less than 2 centimeters. Surgical resection is the treatment of choice for patients with localized HCC in the absence of cirrhosis. You can consider resection in a single lesion in compensated cirrhosis if there is no clinically significant portal hypertension, which is defined as HVPG of more than 10 millimeters of mercury. And also an adequate future liver remnant, which is not universally agreed upon, but generally quoted to be roughly 40% of liver remnant. And we're looking at a 5-year survival of over 70% and a post-operative mortality of less than 3% in these cases. Of note, nothing is perfect. There is data showing that extended criteria for resection is possible. Comparing resection versus transarterial chemoembolization in these intermediate stages, BCLC-B, HCC, actually report a significant survival advantage, has a ratio of 0.56, which leads to every center having some sort of agreement on what can be considered for resection, even if they don't fit the formal recommendations. There's a risk of recurrence after resection. Although it's called curative, we're still looking at a 50 to 70% at 5 years, with the highest risk of recurrence in the first year after resection. Therefore, we recommend a follow-up with cross-sectional imaging every 3 to 6 months with a serum alpha-fetoprotein. Another option, perhaps the best option for some patients, is liver transplantation in early stage HCC. We're looking at a median survival of roughly 10 years, with a 5-year recurrence of 10% now. The backbone of patient selection is the Milan criteria, which was published 20 years ago, almost. And it's looking at 1 lesion between 1 to 5 centimeters or up to 3 lesions between 1 to 3 centimeters. And patients transplanted within Milan criteria is looking at a 5-year survival of roughly 70%, which is comparable to what we're quoting to patients for transplantation for other etiologies. Again, There's patient selection for liver transplant in expanded criteria. We can go beyond the midline criteria because all these different scores that have been proposed by UCSF, Toronto, can give you roughly a 5-year survival of around 70%, which is comparable to other etiologies. Therefore, there's the extended Toronto criteria, the up to 7 criteria, the total tumor criteria, all of which can be applied based on your jurisdiction's particular interpretation of the data and policies. So this is how Transplant Quebec does it. Those who are familiar, there's the MELT score, which is the model for end-stage liver disease. Essentially, we prioritize patients for liver transplantation based on their risk of having a liver-complicated mortality complication, liver-related complication. But for HCC, tumor is driving that and less so hepatic dysfunction. Therefore, we can give exception points based on the size of the tumor. And in Quebec, we use the total tumor volume of 115 centimeters cubed with AFP less than 400, give a MELD exception point of 25, or the HCC MELD. There's 2 concepts that I would like to introduce. The bridging therapy for liver transplant. Essentially, someone who meets criteria for liver transplant, there are risks that they drop out due to tumor extension. And bridging therapy is a local regional therapy or even a combination of local regional therapies that we give patients while they're on the wait list in order to control tumor use and reduce the risk of dropout. There's no formal recommendation of which local regional therapy to choose. It depends on the center's expertise for transarterial chemoembolization, radioembolization, ablation, or even external beam radiation. Another concept is downstaging therapy for liver transplant. In this case, we reduce the size of the viable tumor using some sort of local regional therapy to meet acceptable liver transplant criteria. So patients who are otherwise really good transplant candidates, other than the fact that their tumors are beyond midline criteria or beyond the local jurisdiction's policy for transplantation, can be considered for downstaging to get them to liver transplantation. Again, the UNOS has criteria for this, for successful downstaging. And now we're going to get to these local regional therapies. What are they? Thermal ablation. So a solitary HCC ineligible for surgery should be considered for ablation. So either patient refuses surgery, not a great surgical candidate, or there's some sort of hepatic dysfunction, portal hypertension that precludes them. We can even actually consider an ablation first strategy, which has been shown to be more cost-effective in HCC less than 2 centimeters. They seem to be comparable in terms of recurrence as compared to surgery, and it has the added benefit of not putting someone through a major hepatectomy. Anything that's larger than 2 centimeters, resection has superior survival than ablation. And for HCC that are more than 3 centimeters, and those that are located near critical structures, such as vascular structures, the diaphragm, may be considered another sort of local regional therapy, including external beam or radiation segmentectomy. For unifocal HCC less than 3 centimeters with thermal ablation, the overall survival at 3 years is 76%. For the external beam radiation therapy, in patients not amenable to thermal ablation, this can be an option. It can be used for central tumors and tumors adjacent to vascular structures, and there's no absolute size limit, although most patients on these studies had lesions less than 8 centimeters. Overall, we can say that we should avoid it in hepatic dysfunction, defined by Child-Pugh B 8 or more, uncontrolled ascites or hepatic encephalopathy. And there's a risk of ulcerations, if you use radiation therapy, if the HCC is adjacent to a GI tract, to the GI tract. If these local regional therapies are not an option, then there's transarterial therapies. PACE, transarterial chemoembolization, is the primary option for the intermediate stage HCCs. It's the selective catheterization of segmental or distal branches of the hepatic artery. And there is a risk of deteriorating the liver function, particularly in patients with portal vein thrombosis or significant liver dysfunction. although it's not well established what is considered a poor case candidate, and it varies between center in terms of local expertise. But this is what is being proposed. Essentially, it's a combination of portal vein thrombosis, large tumors, or poor liver function. Transarterial radioembolization, using Y90 glass microsphere, has emerged recently. The Legacy trial, it's a single-arm prospective trial, 162 patients. It looked at Child-Pugh A cirrhosis and solitary HCC up to 8 centimeters, and you had an overall response rate of 88%. And there was the TRACE trial, which was a phase 2 trial comparing Y90 and TACE in Child-Pugh A and B cirrhosis, and you had a better median overall survival at 30 months versus 15 months. Of note, their primary endpoint was not overall survival, was progression-free survival, though. And what happens when patients are refractory to all these therapies, these transarterial therapies? There are definitions of refractoriness to transarterial therapies: 2 TACE sessions, 1 TARE treatment, lack of objective response, or development of new lesions while they're on treatment, or just changing of stage in advanced HCC. Then we have to talk about systemic therapies. So currently, systemic therapy is recommended for patients with unresectable HCC who are not eligible for local regional therapy or who've failed transarterial approaches. There are 2 major groups of medications that are available: the anti-angiogenic targeted therapies and the immune checkpoint inhibitors. Currently, the AASLD guidelines and the ASCO guidelines in 2024 show 2 preferred regimens: atezolizumab, an anti-PD-L1, and bevacizumab, an anti-VEGF, or the combination of durvalumab and tremelimumab, which targets CTLA-4. So the therapeutic targets for immunotherapy is the reversal of the immune evasion from T-cell-mediated tumor cytotoxicity. There are intratumoral cancer-associated fibroblasts and tumor-associated macrophages, which express these high levels of immune checkpoints and essentially evades the immune system by deactivating tumor-specific CD8 cytotoxic T cells, and then promote this immunosuppressive regulatory T cell differentiation. And most of our targets that we'll talk about will be targeting the interaction between the programmed cell death ligand 1 and programmed cell death 1 and then its ligand, as well as the CTLA-4, in combination with one of the anti-VEGF or VEGFR. So the first trial to show a benefit is the MBRAVE 150. At the time, it was comparing in this global open label phase 3 trial the combination of atezo-bev in 336 patients with the standard of care at that time, sorafenib, with the co-primary endpoint of overall survival and progression-free survival. This was a landmark trial in the New England Journal of Medicine in 2020, which was the first one to show any difference compared to sorafenib. The last time this was updated, it was in 2022, published in the Journal of Hepatology. We're looking at 43% treatment-related adverse events in the interventional group and 46% in sorafenib, but you get an overall survival benefit, 19.2 months for the combination immunotherapy compared to 13.4 for sorafenib alone, as well as a difference in progression-free survival. But I think in terms of phase 3 trials in advanced HCCs, we have to look at overall survival or some quality of life measure. Patients need to live longer or live better in order to justify using these type of regimens. I'm not sure about how progression-free survival should be interpreted in phase 3 trials for these patients. But of note, we had 2% mortality, and these mortalities are related to GI bleeding. And we're looking at MBRAVE 150 and GI bleeding. Clearly, there is a higher propensity of patients receiving combination therapy, atezo-bev, to have GI bleeding, not just esophageal variceal bleeding, but other causes of upper GI bleeding. which leads to the recommendation of going through an upper endoscopy prior to initiating atezo-bev. Interesting, also, MBRAE-150 included some patients with portal vein tumor thrombosis. Portal vein tumor thrombosis is very frequent in HCC, and what we call the VP4 is perhaps the most dramatic of them. It's involvement of the portal vein from the main trunk of the portal vein or the contralateral to the primary involved lobe, or both. So in these cases, when we look at the subgroup analysis, they do poorly, even with atezo-bev. The overall survival is perhaps a little bit better than sorafenib, but we're looking at 7.6 months versus 5.5 months. And when we exclude VP4 from MBRAE-150, the all-grade variceal bleeding was actually similar between the two groups. So portal vein thrombosis is probably one that's driving most of these risk of bleeding. And if we separate them based on hepatic function, Child-Pugh A versus Child-Pugh B, this is a publication in the real world for outside of a clinical trial for about 200 patients. If you look at Child-Pugh A patients who receive atezo-bev, their median overall survival is 16.8 months, and then Child-Pugh B is 6.7. So it's clearly the worse the hepatic function is, the worse the outcome is. So the other landmark trial is Himalaya. So this is one with Tremi-Durva. It's a global open label phase 3 trial, randomly assigned 3 regimen. So what we call the STRIDE protocol, tremelimumab, 300 milligrams, and then durvalumab every 4 weeks. Durvalumab every 4 weeks, or the standard of care at that time, sorafenib. And here the primary endpoint was overall survival. This too, for STRIDE, showed a benefit in overall survival compared to sorafenib. The last time anything was published is in 2024, Himalaya, a 4-year update. The 48-month overall survival rate remained higher for STRIDE at 25% versus 15% for sorafenib. And we're looking at median overall survival of 16.4 months versus 13.8. Last month at the is this the S1? No, this is the, sorry. What I want to say about this slide is that is also the latest update that was published. The patients with response to the STRIDE protocol actually do very well. We're looking at a 48-month overall survival of 36%. Compared to those who do not have any radiological response to the therapy. So last month at the European Society of Medical Oncology, they presented the 5-year update of Himalaya. And now we're looking at a 60-month survival of almost 20% as compared to sorafenib, which is less than 10%. So this is Checkmate 9DW. Here they looked at unresectable HCC, Child-Pugh A, so 5 or 6, with no portal vein thrombosis, looking at nivolumab and ipilimumab every 3 weeks, and then nivolumab every 4 weeks, or the investigator choice of either sorafenib or lenvatinib, and the primary endpoint being overall survival. And what we see here, as when they presented it at ASCO 2024, is the median overall survival is in favor of the combination therapy versus the choice of lenvatinib or sorafenib. What's interesting here is you see the crossing of the two survival curves up until 12 months. So it leads us to question whether further refinement in patient selection should be considered here. It seems to do poorly. Is there a subset of patients that do poorly with this combination of nivo-ipi earlier on, and then once we lose them, what we see is the effect of the combination therapy. So that leads to the question of, is nivo-ipi can be considered as another first-line therapy? For right now, it hasn't been recommended as such, but it also begs the question whether nivo-ipi can be used as a second-line therapy for those who failed the initial therapy. So this study was also presented as an abstract at the European study medical oncology. They evaluated nivo and ipi in patients who failed atezo-bev. 49 of them failed atezo-bev, 35 are naive. And we're still looking at a median overall survival of 5.4 months in those who failed atezo-bev. So potentially nivo-ipi can be considered as a second-line therapy for these patients. This is the last study I'm going to talk about in terms of first-line therapy. CARES 310 is a phase 3 trial of 543 patients, randomized 1-to-1. They received camrelizumab, anti-PD-1, and erositinib, an anti-VEGFR, compared it against sorafenib. The primary endpoint was reported as overall survivor plus progression-free survival. It ended up being a positive study, mainly based on the fact that progression-free survival was different. But again, phase 3 trials for first-line therapy, if we fail to show an improvement in overall survival, a bit harder for me to interpret in terms of the utility of this regimen. But also we have to note that the treatment-related adverse event was very high, for grade 3 at 81%. And most of these patients were recruited in East Asia, so also plays along with the external validation of this trial. So now what does the future hold? We kind of went through what the immunotherapy has done for advanced HCC. It really drastically changed the landscape. Prior to IMbrave 150, all we had to offer was sorafenib or lenvatinib. So now people are looking at neoadjuvant treatment for in early HCC. Everything is still early right now, phase 2 trials. KSEP presented at ASCO an abstract of neoadjuvant nivo or nivo-ipi prior to resection, patients with early HCC, and reported 17% grade 3 adverse treatment-related adverse events. And Marone published neoadjuvant semolizumab before resection and reported the 15% tumor necrosis. Now, I want to talk about adjuvant treatment for high-risk resectable HCCs. There are several ongoing trials. Checkmate 9DX, that's adjuvant nivo. Keynote 937, that's pembro, and Emerald 2, looking at durvalumab with or without bevacizumab as adjuvant therapy. But the most important one I want to talk about is MBrave 50. So this was published last year and got a lot of excitement around it. Phase 3 trial comparing active surveillance against adjuvant atezolizumab plus bevacizumab after curative intent of either high-risk surgically resected or ablated HCC. Here, first problem with this trial, the primary endpoint was recurrence-free survival. We did not look at overall survival as a primary endpoint. And 668 patients were included with a median duration of follow-up at the time of publication of the interim analysis in 2023 of 17 months. And the interim analysis was positive. But already there in 2023, there were several letters to the editor saying, if we look at the curves, maybe they're starting to meet in these patients. So there was a question whether this is actually a positive trial. Nevertheless, it got a lot of excitement going, so much so that the AASLD recommendation that was also published around that time started to say that we can consider adjuvant immunotherapy in patients with high-risk resectable HCCs. But last month, when they updated the trial, it was a negative trial. The updated progression-free survival was 0.90, crossing 1. And so what ended up being a very exciting trial was negative. And this brings up a good point in terms of the issue of interpreting interim analysis in trials. First of all, the assumption of the proportional hazards, which is the underlying linear relationship in survival analysis, is not always true. And there's also issues with recruiting patients with such heterogeneous disease. There's the heterogeneity in the patient recruitment process. So is the variability in the way patients were recruited earlier in the trial and later on may explain the initial promising results that did not persist on the latest update at ESMO. So for now, we still don't have a clearly positive trial for adjuvant immunotherapy. But what about immunotherapy added to the treatment of local regional therapy or added to arterial therapy for the intermediate stage HCC. So Emerald-1 here, presented as an abstract in ASCO, is a phase 3 RCT, durvalumab with or without beva plus TACE. Here you have stage A, stage B, and stage C, and they were randomized to receive combination plus TACE, durva plus TACE, or TACE alone. And the primary outcome here was progression-free survival, and it was 15 months compared to 8.2 with a hazard ratio of 0.77. Another trial that was presented last month at the ESMO conference is LEAP-012. Here they're looking at the combination of lenvatinib and pembrolizumab plus TACE versus placebo alone plus TACE in patients who were eligible. Of note, they did not have anyone with portal vein thrombosis or extrahepatic disease. And the progression-free survival here was also positive. Their primary outcome was the combination of progression-free survival and overall survival. The overall survival results was still immature, but this is promising in terms of progression-free survival with a hazard ratio of 0.66. And the overall survival was trending towards favorable for the combination of therapy, as you can see here. And now what I find really interesting and exciting, but quite still, I guess, immature in terms of data is immunotherapy. Can we use it for transplantation? Can we bridge them for transplantation or even downstage them for transplantation? The issue with immunotherapy in transplantation has always been the risk of rejection. Modulating the immune system prior to transplantation and then subsequently trying to control it with immunosuppressant can lead to cases of rejection. And also the addition of bevacizumab to a regimen causes vascular complications in patients, and after a delicate surgery, because that also persists, leading to vascular complications of post-transplantation. But there are several trials investigating this very question. ImmunoXXL, liver transplant patients beyond the up to 7 criteria who had a partial or complete response to atezolizumab and bevacizumab, they actually presented an abstract at the EASL in June, and at that time they've recruited about a dozen patients who underwent through transplantation, and they've had one case of hepatic artery thrombosis. So we await for further updates. There are people evaluating durva, tremi, pembrolizumab, lenvatinib, and combination of atezo or tremi durva. The Vitality study, this was recently published in the Journal of Hepatology, looked at 117 consecutive patients with HCC treated preoperatively with immune checkpoint inhibitors. 86 exceeded Milan criteria, and 65 were downstaged successfully with a median time of roughly 6 months between starting immunotherapy and receiving the transplantation. 43 underwent liver transplantation, with 18 within Milan and 23 were downstaged. And there was no grade 4 or 5 adverse events while on the wait list. There was rejection seen in 7 cases. In itself, 7 cases out of 43. It's a little bit on the higher end in terms of rejection, but it is still reasonable and what is reported in some centers. 6 of these patients received immune checkpoint inhibitor within 3 months of liver transplantation, and which resulted in 1 graft loss. But I think these results are promising, showing that it is feasible to bridge these patients with immunotherapy, and further studies will clarify this question. So in conclusion, what has immunotherapy done for the field of hepatocellular carcinoma? In advanced HCC, it really changed everything. But in the addition of immunotherapy in adjuvant, neoadjuvant, and early stage HCC, it's still under investigation. Embrave-50 was very exciting last year, ended up being negative, so we await for other trials to see what's going on. And the addition of immunotherapy to TACE actually might improve outcomes. Now we have 2 trials that showed some sort of benefit in terms of progression-free survival. And finally, for the future, immunotherapy for downstage to bridge or transplantation, although I'm not sure what's the end results for this, but it is plausible and should warrant further investigation. Although I think we should tread really carefully with patients that we're bringing for transplantation, because any graft loss is disastrous. It's a loss for the patient, and it's a loss for the donor. So I think being too aggressive in this domain too fast might actually set back the field than anything else. But it is plausible, and we should carefully consider patient selection for these. Thank you. And I'll take any questions.
Thank you. Thank you very much. Thank you for this comprehensive presentation on a very difficult topic. You can enter questions in the chat, and I'll take questions in the room. I'd like to start. Can we just take a step back? You talked about risk factors, if I understood correctly, cirrhosis. Is alcohol in of itself a risk factor? And you said something about cereal. Can you elaborate a little bit on that?
So alcohol per se the data is not clear whether alcohol per se is a risk factor for HCC. It definitely worsens your liver disease. And there's fatty liver or met ALD, a combination of fatty liver and alcohol, that increases your risk of having HCC. And what was the second question?
The cereal, you said.
Oh yeah, just aflatoxin is it's found in some agricultural products and in areas in tropical areas, and that's a risk factor for developing HCC.
So nothing that we have in our cereal, local cereal.
We like don't. As far as I'm concerned, we don't have a aflatoxin problem with our cereals.
Yes, Dr. Roger.
Yeah, great presentation. Thank you. I'm just curious about you raised portal vein thrombosis and tumor in vein as poor prognostic factors. Is that because they're a surrogate of the disease activity, the cancer activity, or are these patients sort of at higher risk of GI bleeding, venous gut infarcts by Chiari? Like, what's the mechanism of death in that higher risk group?
Can you just repeat the question?
So thanks for that question. So the question was, in patients with portal vein thrombosis, what do I think is the mechanism of death for these patients that have such poor outcomes? I think it's a combination of both. Obviously, the liver derives 2/3 of its vascular supply from the portal vein. So if you have a portal vein thrombosis that's quite extensive, some of that is cut off, and I would expect to have poor hepatic function from the get-go. And we see that patients with declining liver functions do poorly regardless of immunotherapy, regardless of which type of immunotherapy. In terms of mechanism of death, yes, these patients have more events related to GI bleeding. And now there's no formal recommendation of what to do in terms of should we have ongoing screening while they're on atezo-bev. We definitely screen them beforehand. But once we exclude these patients, these portal vein thrombosis from the trials, their risk of bleeding is actually similar to that of sorafenib, because sorafenib in itself can cause some sort of GI bleeding as well.
Now we have some questions in the chat. Phil, would you like to unmute yourself and ask your question?
Hi, Sun. Great talk. Really enjoyed it. It really seems to me that prevention is really important, and NASH is really exploding nowadays. Do you see stratification coming for NASH like we do for hepatitis B? You know, like screening at age 40 for men, etc., even if not cirrhotic or F3? Because I think that it's so prevalent nowadays that it seems that prevention seems to be the key in that condition.
Right. That's a really good question. I think Giada, who's the Canadian expert on fatty liver, has her finger more on the pulse for this data. But in terms of screening, as far as I'm concerned, there's no validated scores on a large scale that's made it into recommendations for these patients. But there's definitely coming, and there's actually publications on using machine learning to cluster these different type of phenotypes based on, multi-omics data, histology, risk factors, patient-related risk factors to identify those who are at higher risk. But obviously, this is just a retrospective observational study that used some fancy machine learning algorithm before it gets ready for formal clinical use. I think it will take some time.
Thanks, Xun.
Thank you. Dr. Rosenblatt, would you like to unmute and ask your question?
Thank you. That was really, it's a bit esoteric, but hereditary tyrosinemia is a Quebec-based disease, and the patients are now picked up on newborn screening and treated long-term with NTBC, which is supposed to eliminate the risk of liver cancer. I was wondering whether we see any adults or beginning to see any adults who have been treated from birth with NTBC, because the treatment's been around a while, and then how you would be screening them differently or any differently, because I didn't see it as one of the risk factors under metabolic.
Yeah, I haven't followed any of these transitional clinic patients for hereditary tyrosinemia. I would presume that their risk of HCC, to me, would be screened based on the same recommendations if they don't have cirrhosis. But yeah, that's a good question. I don't have a good answer for that.
Thank you.
Can you tell us a little bit at the MUHC in terms of all these biologics that you went through? There's a lot of studies, ongoing studies. What do we have access to for our patients? Are we sort of using the state-of-the-art kind of treatments, and what kind of costs are involved in this?
I think the search, I mean, I just started here. I'm trying to integrate into the surgical oncology clinics. I think Prosanto mentioned that we are participating in the Emerald study for its combination of TACE. Otherwise, we were also part of MBRAVE, but what's ongoing right now, I don't know what we're recruiting for. Yeah, other than these two.
And are there any that are not in trials but already available for use? And if so, do you have any idea of the cost of these agents?
So, yeah, so we have done cases of transplantation with patients that we treated with immunotherapy, but this is like how all the other centers done, right? It's just based on case series, case reports. In terms of a formal trial, I don't think we have any that's ongoing, but it is feasible. We just have to be wary of the complications, mostly vascular and rejection.
And in these patients that we would be following at the MUHC on some of these novel medications, just for the audience, what are we looking for? You just mentioned for the liver transplant, but just generally speaking, what kind of complications are these patients going to be presenting to the emergency room with, and what should we be looking for?
So, yeah, great question. For those patients who are on atezo-bev, bleeding is the main concern. So any sort of GI bleeding, and anything related to autoimmunity. So thyroid disease, they can have also nephropathy. They can have proteinuria. But the main one that's really concerning is bleeding. And of course, with Tremi-Durva, you lose the bevacizumab, therefore you don't have bleeding, but you have a higher risk of having autoimmunity with that compared to atezo-bev.
And finally, just are there any other questions here, Mark? Yeah, Mark Roger. Yeah.
Maybe just from a health services and Quebec context perspective, if we're doing screening ultrasounds every 6 months for cirrhosis patients, and you know, we hear in other contexts that there are communities of ultrasound techs and availabilities of ultrasound imaging that are limited. Is that an issue? Are we able to deliver on the guidelines in the Quebec context currently?
I would say in the patients I've been following in clinic, been relatively okay for people that are within the greater Montreal area. The main issue is someone from northern Quebec, further territories. In most cases, when I see referrals, the ultrasound has been outdated for about a year. So maybe they're getting one ultrasound a year is I typically see.
So the question was about availability of ultrasound. So just in terms of, who we should be sending to your clinic or your team's clinic, if I understand it would be sort of anyone with a diagnosis of cirrhosis. Is that appropriate?
I mean, anyone with compensated cirrhosis can be followed up just with screening ultrasound. It's really, I think, I mean, we're happy to see them, but I think the real people that we can make a difference as a hepatologist for is decompensated cirrhosis, anyone with complications, because otherwise, with compensated cirrhosis, it's following with screening ultrasound, EGD if that's warranted, depending on their their liver stiffness and platelet count. But decompensated cirrhosis definitely a welcome any possible for that.
Do you have any data on cardiac cirrhosis? Is that a problem for these patients? Is this higher risk?
Higher risk of developing HCC from cardiac cirrhosis. Cardiac cirrhosis tend to develop these focal nodular hyperplasia from the congestive hepatopathy, like the remaniement of the vasculature, and then you can often see them, and they take a little bit of work. You need to clarify between that and HCC, but outside of this context, I don't think their risk of developing HCC is higher than other causes of cirrhosis.
Okay, we have a comment here from Martine.
She says all lesions should be sent to HPV clinic directly to Dr. Zhao or any of the surgeons. Yes, that is the plan. Yeah.
Fantastic, fantastic. Okay, if there are no further questions, I'd like to thank you very much for this very comprehensive review. It's great to see a field that's advancing in the very recent publications, and I'm happy to hear that we're involved in some of these clinical trials. So thank you very much for your presentation. I wish everyone a great afternoon. Thank you. Bye-bye.